Thanks for listening today. I want to be transparent with you. Besides hosting this podcast, I also work for Everly Health, our sponsor for today's episode. However, all views and opinions expressed on the podcast are my own or those of my guests, not those of Everly Health.
All right, welcome back to Digital MD, the podcast where we talk to leaders in the digital health ecosystem about innovation, decision-making, and how they think. I'm your host, Dr. Liz Kuo, and today I'm thrilled to have Dr. Aditi Mallick with us. So I think we'll go by Aditi. She's the acting director of CMS Office of Minority Health, leading health equity initiatives across CMS policies, programs, and partnerships. She's had significant roles with CMS, including chief medical officer for Medicaid and CHIP services, focusing on health equity, social determinants of health, and whole person care. So the funny thing is, we talked about this earlier she went to Harvard for college and Stanford for medical school. And I did the flip. So I went to Harvard for medical school and Stanford for college. And we were talking about how we still practice medicine, applying our clinical insights into our leadership roles. I think for you, Aditi, it's amazing to see what you've done at CMS, being able to mesh and build your background. And I really love, I think a lot of your focus has been figuring out how to straddle health clinical work, opportunities, looking at all the different ways that you build and create a voice for minority health. I'd love to dig in deep and sort of hear your background and your work experience and what made you want to work at CMS.
Sure. Yeah. I think like a lot of people that work in medicine or healthcare, it was a personal story first. So I'm the daughter of immigrants. Both my parents were born in India. I'm the only American citizen in my family that was born on US soil and not a naturalized citizen. My parents were small business owners. And in the fall of 1997, my dad started to not feel well. And he was born in India, spent his formative years in the UK, so he was a British citizen. And it was cheaper for him to get on an airplane to fly to London to see a doctor in the NHS than it was to navigate the US healthcare system and to find a doctor here. Because they were small business owners, this was before the Affordable Care Act, and they didn't have health insurance. Um, that visit led to a diagnosis of esophageal cancer that over the ensuing 9 months was awful, was really, really awful. I watched my mom run a business, raise 2 kids, try to scrape together money for chemotherapy infusion, all of which ultimately ended in losing my dad on May 6, 1998, a day I will remember forever. And at the age of 12, when my dad passed away, remember thinking...
You're making me cry. Sorry, I'm
Yep,
like
go
just...
ahead. But in the wealthiest country in the world, why did it have to happen like that? And so I remember thinking, well, and this is maybe just reflective of 12-year-olds think, I guess, but I remember thinking, oh, I should be a doctor so this doesn't happen to somebody else's family, right? I couldn't change what had happened to my own family, but maybe if I knew more, I could have been a better advocate, or I could help make this less painful or less awful for somebody else's family. So I went to college sort of thinking I would be a doctor. And then I had the great fortune of taking classes in college with Don Berwick and David Blumenthal and the late Dr. Paul Farmer, and became enamored with this idea of what I now lovingly call Doctor Plus, right? People who are trained as physicians or clinically trained really go on to spend the bulk of their time on healthcare systems. And for me, that's what really deeply resonated, because that's ultimately what had drawn me to medicine in the first place, was this realization that there's something so, so magical, and it's such a privilege to be able to be one-on-one with a patient or their family at their most vulnerable moments or transitions of life. At the same time, it's so compelling to me still to be able to work on health systems that impact thousands or millions of people's lives at once, particularly in light of the fact that our healthcare system has so many things that ought to be better, right? Again, in the wealthiest country in the world, ought to serve people better, ought to be more accessible, more affordable, more person-centered. And it's, we're getting there, but it's not. And so that's ultimately what drew me to medicine, and then sort of by extension into healthcare. And then the journeys along the way since then have really been kind of in service of the dual mission, I would say, of one patient at a time or one family at a time, alongside that pursuit of broader health system impact.
Well, thank you for sharing. I was able to collect myself while you were telling me the story. And I just, I feel like a lot of us can draw very deep into the experiences we've had to basically drive the mission that we have to. So even for you, it's amazing to see your diversity of expertise from your focus on breakthroughs of empathy, intellectual curiosity, to academic medicine and public service. So I'd love to delve in deep into your career in terms of how can you tell me a little bit more about what your day to day is like when you're at CMS? Like, how do you approach embedding health equity principles to the CMS policies and programs? And what challenges do you see encounter every day?
Yeah, so there's a lot in there. I'll start with maybe just what do I do? Like what is my day
Yeah.
job? So I'm currently serving as the acting director for the CMS Office of Minority Health. So we are one of 25 centers and offices, 26 centers and offices across CMS, but our specific charge is the advancement and integration of health equity into CMS policies and programs. Our office was set up by the Affordable Care Act in 2010, so relatively a newer part of CMS relative to things like the establishment of the Medicare program or the establishment of the Medicaid program. But writ large, for folks that don't know, CMS as an agency overall oversees the Medicare program, the Medicaid and CHIP programs, and the marketplace that now collectively insure over 160 million people in this country. So 1 in 2
Amazing.
Americans are in some way enrolled in a program that CMS oversees or touched by a program that CMS oversees. So my day to day, and it's trite, it's almost trite to say this, but no 2 days are alike sometimes. So it's a mix, I would say, of policy development, policy implementation, some things that are sort of very early stage that'll make their way into policy vehicles, some things that are already in legislation or in statute from Congress that CMS is charged with implementing and ensuring that we are my role, or collectively our office's role, is ensuring that the impact of those policies on individuals or communities that are often underheard or underserved isn't an afterthought, but rather
Yes.
at the forefront of the thinking, right? So, what does this look like for individuals with disabilities? What does this look like for people for whom English is not their primary language? What does this look like for people living at or below the federal poverty level? People that might have limited health literacy, and I could go on and on in the varieties of people or populations that might be impacted by different things. And then I get to do a lot of, I have the good fortune of being able to be a spokesperson for a lot of the great health equity work and policies and programs that are coming out of the agency. And then a good portion of time spent on internal things too, the more operational managerial side of running an office and running a team. It's
So
fun.
with it sounds amazing. It sounds like also it's a lot of management, stakeholder alignment, building out the structure for things. If someone, let's say a digital health entrepreneur or someone who really cares about minority health, or they have a certain focus, how do they navigate CMS if they want to learn more? One thing is website, but if they wanted to find out, let's say, what is Aditi focused on? Like, how can I work with her? Where do they start?
Yeah, what a good question. I'm reticent to say like just email me, but that kind of is in some way the easiest answer. But I mean, so surely going to the website and understanding a bit about how CMS is structured, what the different offices and centers across CMS do is helpful, all of which is available on the CMS website. And you'll get a sense of what the functional statements or really
Mm.
the mission for each of the parts of CMS are. And again, will sound obvious, but a lot of the CMS news alerts too will give you a sense of which parts of the agency are sort of engaged in or in the driver's seat for different policies or programmatic areas, which is another helpful lens on really getting inside the belly of the beast of how things happen within CMS. Because I can certainly respect, and I hear not infrequently that it can feel like a bit of a black box to understand what happened with
Yes.
these four law.
Because part of it is, we want to educate people more on what the government is doing, what the mission is, and roles of partnerships to play in advancing health equity, both on, let's say, any digital initiatives, any kind of ways where we're innovating. Even for Everly Health, the company I work for, we spent a lot of time building alliances to understand how do we get fit tests, so colorectal cancer screens or chronic kidney disease tests to Medicaid populations, to populations that don't have easy access when there's no physician footprint in their community. And then also, how do we follow up with educating and then not just testing, but then treating and or advocating? So with these types of innovations, I'm always curious to hear from government folks. How do they get involved? How do they learn more? And how do they help align with the mission that you're driving?
Yeah, I appreciate the question. I mean, I would say first and foremost is it's certainly helpful for us to have awareness of what types of innovations are out there. I think the other thing that's really helpful for us is to hear where policy is either an enabler or a barrier to uptake or barrier to access, right? Which is not to say that we CMS necessarily hold the levers to remove all barriers, right? There may be barriers that exist because of policies at a state level or interpretation within a given health system or things like that. But really understanding those challenges
Yeah.
to know where policy levers that CMS does hold can be enablers of innovation and enablers of access. Because I think, again, if I zoom out to the 30,000-foot level, I think fair to say that we all share an overarching mission of wanting to ensure that all populations, regardless of what they look like or what language they speak or where in the country they live, have access to the latest and greatest high quality person-centered care.
Yes.
The other thing I'll say from a CMS perspective is that not CMS actually runs a number of different programs, right? So coverage policies, for example, in the Medicare fee-for-service program might look different from coverage policies for the Medicaid program or for CHIP
Yes.
programs, right? Where really Medicaid and CHIP in particular, CMS's role is much more in setting guardrails and oversight related to fiscal integrity and program integrity and certainly strategic direction. But the specifics of things like provider enrollment, specific coverage policies, reimbursement rates are really at state discretion. And so I think there's also some bi-directional education that I find is often useful when people have ideas about products or services and say, well, why won't CMS cover this? It's usually because it's not within CMS's purview to make that sort of decision, particularly in the Medicaid program, which is the area where I would say, just based on my own experience, comes up the most often.
Let's dive a bit deeper because I get these questions all the time about how is Medicaid organized and who is the decision maker state by state versus what does CMS, for example, you coming from minority health and managing that. So can you give people insight into that state by state, who organizes the reimbursement models and whatnot, and how do they learn more about that?
Yeah. So in any given state, the policies around, again, who can enroll in the program as a
Yes.
provider, what services are covered versus not covered, what the reimbursement rates are for those services is at state discretion. So
That's right.
the things that CMS, and that specifically would be a state Medicaid agency or a state CHIP agency, the things that CMS oversees or regulates in that domain are largely things that are enshrined in statute. So, for example, in the Medicaid program, there is enshrined in statute a set of benefit categories. Any covered service, and there are mandatory benefit categories and optional benefit categories. Any service or support, technology, device, DME has to fit into a benefit category in order to be covered by Medicaid. There are, as I said, a set of mandatory benefit categories that every state has to cover. And there are a set of optional benefit categories that states, as the name implies, can cover at their discretion, meaning they are optional for states as part of their state's implementation and operationalization of their Medicaid program. And so, I realize for some people can be a bit of an unsatisfying answer to say, well, okay, we got FDA approval, or okay, now there's a new code for this, right? There's a HCPCS level 2 code for it. Why can't we just wave a magic wand and have every state Medicaid fee for service or every Medicaid managed care organization in the country cover it? And unfortunately, that's just not how the Medicaid program was designed. It was really, from its inception, designed to be a state and federal partnership where, again, the federal government's role is really oversight, guardrail setting, and federal match, right? So the federal government
Yes.
funds a good share of the Medicaid program, but the actual operationalization of the program is largely at state discretion.
And so for innovators, do you recommend that they go state by state, or can they then aggregate and think about, going after one state, let's say, for example, a larger state, or how do you recommend where they start?
Yeah, it's a good question. I mean, I would actually start from a bit more of the first principles of how does my innovation, whether it is
Great.
again, a service, a device, a pharmaceutical, what have you, how does my
Mhm.
device fit into a benefit category? Because that is actually a
Great.
threshold test, right?
Yes.
So because that forms the basis for what is the underlying on the commercial side or on the business side is what's the business model? How does that business model translate into a reimbursement model? And the linkage there between a business model and the reimbursement model is the benefit category, right? So if
What I'm
if what you
hearing
are
too.
proposing, oh, go ahead.
Oh, no, I was going to say, what I'm hearing too is there's a lot of language of people learning how the government thinks and the benefit
Yes,
categories and the specific terminology, because I do think it aligns with what the state is looking for, so that you can then create, let's say it's a digital app, let's say it's a mental health, behavioral health app, that it aligns with the state needs and the benefit category that they're looking for.
Yeah, I think the other thing that will always be true, again, regardless of whether you reach out to a given MCO first or a given state Medicaid agency first, and that I'm sure a lot of BD folks out there have all sorts of thoughts on, but clarity around benefit category is important. So too is, oh, and I just forgot what I was going to say. It'll come back to me.
Okay, but definitely clear language around benefit
Oh,
category.
I remember. Yes. Clarity around benefit category and then outcome.
Mm.
Right? The ability to show that your intervention has had some sort of meaningful impact, whether that is on patient engagement levels or on A1C levels or blood pressure control or, what have you. But I think the folks that I have seen be successful at this are people that are able to tell an impact story supported both qualitatively and quantitatively. And
That's
then, some of
amazing.
it really is just really kind of traditional sale, if I can call it that, right? And a lot of
Mhm.
which ends up being, retail as opposed to in aggregate. And that's again just the nature of the Medicaid program.
Great.
Did you know that improving preventive care can significantly impact your health plan star ratings? Everly Health Solutions is the leader in at home testing for health plans. Their convenient, member centric approach has helped plans achieve industry leading results. In just 1 year, Everly Health Solutions helped a multi state Medicare group improve 15 of their plans by at least 1 star. That's a win for members, providers, and the plans themselves. Learn how Everly Health Solutions can elevate your health plan at everlyhealthsolutions.com.
And I think one thing, as we reflect on some of your time as a chief medical officer for Medicaid and CHIP, have you seen specific innovative strategies as we're talking about getting in, and what have you seen as like a successful implementation of something that's innovative within the health equity space? Or and that I think the following question is also, how do you uh, bridge your background with the clinical and the medicine and the policy? Because I feel like you, going back to all the ability to, you see policy and you know the standards, you know stakeholders, and you're also able to think about the clinical benefits, like you said, outcomes, because it's just an incredible, I think, skill set that people could model themselves after and learn from.
Thank you. That's very kind of you. I mean, on the first question around innovative strategies, I think the most, and this is a little bit to what I know might be one of your later questions of what am I excited about. I think
Yes.
increasingly I am seeing innovators, entrepreneurs, investors really think about working in Medicaid or in the Medicaid space, not as an afterthought, but as the entirety of the business model, right?
Mm.
That I think for a long time, people would develop an app or a service, but it was targeted to or tailored to a rather different demographic, right?
Yes.
It tended to be, as an example, right? Higher SES, higher education levels, not necessarily available in multiple languages, not necessarily accessible in the broad sense of the word, not
Yes.
necessarily reflective of unmet health-related social needs or social drivers of health that we know have a disproportionate impact on downstream health outcome. And I think there's increasing traction around, rather than starting with one population and trying to retrofit for a Medicaid population,
Yes.
to really
Mhm.
intentionally build for a Medicaid population. I think the other thing I will say, and I just did it just now, the Medicaid population is extraordinarily heterogeneous, right? Medicaid,
Yes, very diverse.
40% of the Medicaid population is children. Medicaid covers 40+% of births in this country. That number goes up depending on the racial and ethnic background of the birthing parent. But, Medicaid, by virtue of eligibility categories, is a predominant insurer among children in this country for people that a dominant insurer among people who are low income, a dominant insurer among people who live in rural areas, a disproportionate insurer of people who are immigrants or first generation Americans, right? And so to say a quote unquote Medicaid population really does a disservice to how heterogeneous that population is. And I think that there is now also increasing recognition around, well, look, in the same way you would do customer segmentation for any other
Mhm.
commercial product, it really behooves you to be quite tailored and focused around, well, who is my intended patient population or my intended audience? Because even within Medicaid, that could look very, very different.
That's such a good point. I also love the idea of just kind of drilling in on a specific Medicaid population and then kind of replicating that versus like a general app that, as you said, doesn't have a reading level of like second grade and isn't in multiple languages. Some of those things I think people overlook, but they're essential for building in not only the cost of that and access to that, but then for you to be able to scale and be successful in the stickiness and the ability for people to use it.
Yeah. And
Uh,
I would even go so far as from a BD perspective in sales. Like, if you're trying to sell, if I can be so blunt, if you're trying to
yes.
sell to an MCO or a state Medicaid agency, if the population that you have deployed your technology or your tool or your service in doesn't reflect the population that they serve,
Mm.
that's a problem, right?
Yes.
Why would I buy a product if I don't know it's going to work for the people that I need to help?
I completely agree. We're doing this now also with different language models to allow for when they're, and so it's just, it's very important. And people don't always factor that in when they're building out their various innovations. So another thing I think as we talk more about some of the ways that you're incorporating SDOH, or social determinants of health, into healthcare models and policies, how do you look at that from a holistic point of view, from the minority health outcomes that you're looking for? I would just love to understand your sort of your framework when you're championing this. Is it based on volume? Is it based on like successful outcomes? Like how do you, what's success look like for you in your role?
Yeah. Also such a multifaceted question. I mean, I'll start with the social drivers of health. The fundamental premise there is now undeniable that social drivers of health drive a disproportionate impact on downstream health outcomes, right? It's not what you or I or anyone else in a white coat does.
Mhm.
It's, do you have stable housing? Do you have ready and reliable access to nutritious food? Do you have a way to transport yourself to the necessary places that you need to be? Right. And those
Yes.
things are far more important, right? Can I afford my medication? Those things are far, far more important than what we think of as traditional healthcare interventions, right? How many times in a year did you see a doctor?
Yeah, exactly. Did you like go to your PCP? Are you being followed? Are you getting these screenings?
Exactly. Did you get a flu shot this year? Which is important. Don't get me wrong. I am very pro flu shots. Everyone should get vaccinated, right? Like, everybody get your CDC, ACIP recommended vaccinations, right? But
Right.
there are a lot of there are factors that supersede those in terms
Yes.
of the proportion of their impact on an individual's health. And so recognizing that as sort of undeniable, we are trying to incorporate into our policies and programs and intentionality around screening and addressing those social drivers of health, right? And you see that now across a number of CMS programs, whether it's in the Medicare program, on the Medicaid side, across a number of innovation center models, right?
Mm.
In terms of what does success look like, I think there's a number of different ways to answer that question. I mean, the holy grail that is often touted is the combination of improved health outcomes, improved patient experience, and reduced cost, right? The so-called triple aim or quadruple aim, if you want to include provider experience as
Yes.
well. I
Right.
think which is a whole nother conversation around burnout, frankly, and honestly, the moral injury and burnout associated with taking care of a population whose social drivers of health are going unmet or health-related social needs are going unmet. And I certainly felt that way in my time as a hospitalist. Um, anyway, all of that to say, I think we are looking at outcomes across a variety of different lenses, right? Including the ones I just said, the impact of addressing health-related social needs on health outcomes, on quality, on cost, and on experience. And there's a number of, as I said, exciting interventions and innovations in this space that'll be important to watch over the coming years.
That's great. I was going to ask you about some of the interventions, some areas that you're interested in. So I think we have about 10 more minutes. So I wanted to ask for some advice that you would give to emerging healthcare leaders who are passionate about health equity, what you would tell them, and then also interested in hearing about your future belief, like what is the focus for furthering health equity in the future, whether technology or other areas. And then I also want to spend some time learning more about how you've adjusted from the provider side into where you are now in DC. And we can talk a bit more about, I've moved around from California to Boston and the East Coast, and you and I flipped. So I'd love to hear how you've accommodated and adjusted everything, because it's been cold in Boston, but warmer than normal. And we can talk about some of the California weather and how I can't wait to go back. But we just have a lot of experiences that I think I'm sure we share together.
Yeah.
So let's start first with future leaders, advice that you would give them.
Don't give up. I think it's probably my best piece of advice. The other will also sound trite, but define your why, because there are going to be some really good days and there's going to be some really hard days where you question, why do I do this? Why am I trying to push a rock uphill kind of thing? Or progress is so slow, I wish it would go faster. And I often find myself on those days reminding myself of two things. One, what an extraordinary privilege it is for me to do what I do and live the life that I live. And two, that I chose this for a reason, right? And I told you about my dad, but that for me is the why. Like I do this so that every family that comes after mine doesn't have to go through what we went through. And that gets me through good days and bad days.
I really, really like that. Warren Buffett always talks about, when people ask him, like, what led to his success? He said, I was born into this country and I was lucky enough to have the resources and look for, and like you said, sometimes we don't always think that we have the choice, but we do have the choice. Like we chose these careers, these professions, and we are more than lucky to be able to serve a certain population that we came from. I grew up with a rat-infested garage where the landlord would drive their car into our dining room, which was the garage. And so I think that's why it really resonated with me and why I got emotional thinking about all the things that your family went through and why we were in a privileged position to make changes. And so the next thing is then, what do you see as the future of health equity? And what are exciting areas you think we should be talking about to further that?
Yeah. I mean, I think I would be remiss if I didn't say I think we're at an inflection point. I do think there are people across this country that react very vehemently to the idea or the terminology health equity, right? And I think that term gets vilified by a lot of people for a lot of different reasons that I won't necessarily get into. And when I think about how to sustain the movement going forward, I come back to how do we anchor in why we do this to begin with, and that there are disparities in this country that are avoidable and are preventable. So regardless of how you think about categorizing people, and I think there is a very strict legal precedent around benefit or burden to certain people based on racial or ethnic classification, as an example. If for a moment, and I certainly don't mean to put aside issues of persistent and severe racism. That's not what I'm trying to do. But what I am trying to say is for the sustainability of the movement, I do think it's important to anchor in the idea that health disparities at their core are avoidable and ought not to exist. And it behooves us as leaders to really be examining why they exist and what we can do, at least from a policy perspective. And I would offer that charge to anyone listening from your own vantage point, what we can do to mitigate those disparities. And so what I would say is, again, people get caught up in the terminology, but really to anchor in the underlying point, which is that some people have and others have not in terms of good health and well-being. And there are things that we can do to help advance fair and just attainment of good health for all people.
I really appreciate that. I think you're right. Sometimes there are, again, not overlooking any people's opinions and, life experiences and what they share, but that if you don't forget, there are ways that we should be driving the movement ahead for the ultimate good of society and of the people that we should be serving. If you don't forget that, I think then you're able to move ahead with some of the differences in how you interpret that and all of the good work that you're doing. So another thing I was thinking about is just helping listeners understand why you chose this path and how you have lived in different places and your experiences across from, we were talking about the frigid cold of Boston and like your high heels getting stuck in cobblestones to where I've experienced to being in Stanford where my professors were always in tie-dye t-shirts and shorts. And if you experience that same different cultural difference or, what it is in DC and how those are different.
Yeah. I mean, what I would say is climate aside and personality stereotypes and realities aside, you can find great people everywhere.
Yes.
Right? And that's, I think, probably the biggest learning that I've had. I've lived in a lot of different places now over the course of my years personally and professionally. And there's not so great and really extraordinarily great people everywhere. And some of them wear flip-flops and tie-dye. Some of them wear snow boots and parkas. Some of them wear like in between fall jacket. But yeah, I think my career in various transitions have really always been about finding your people. And I've been so lucky to have found my people. And by that, I mean people who are motivated by the same types of things or whose mission personally or whose personal set of values align with mine, even if whether they're in medicine or not. The people who either by virtue of experience or just by virtue of who they are aligned in how they see the world and how they see themselves in the world and motivated really by a sense of service and a sense of, honestly, in some cases, obligation to do better. And like I said, I've been fortunate to find those people in the DMV, like the DC, Maryland, Virginia area. I've found them in California. They live all over the place. They live in the heartland. They live in the frontier West. They're all over the place in this country and I think all over the world.
I love that. I've been recently reflecting on this and how I want to have in my inner circle, whether you call it your own board of directors or your tribe, it's finding the smart, insightful, kind givers that are a force to show you the goodness, because there's so much around the world sometimes that is filled with other negativity or other things, people saying you can't do this or you won't be able to do this. And as opposed to listening to those voices, it's to figure out how you can work with people that are affirming and help you with your determination. And I really think if you're able to kind of quell those voices and figure out the ones that you align with, you can be your best self. And it sounds like you've really found that with where you are. Yeah, that's amazing.
Yeah.
As we always do with the closing of the show, it's been an absolute pleasure. And before we wrap up, I always ask our guests for their hot take, the 5 questions. So we want to make sure if you're ready. So the first is, what's the best advice you want to give anyone?
You set the tone for how people treat you. So the things you say between your own 2 ears are reflected in what you say and do to the world around you. So be kind to yourself, and that'll set the tone.
That's great. I love that. Oftentimes we are our worst critic. So I really think being kind to yourself is something that is key, because then you end up being kind to others because you give yourself that grace. What about your favorite business or life quote?
The best time to plant a tree was 20 years ago. The second best time is now.
Mm.
Right? Never too late. You're not too old. You're not too young. You're not too anything. You're not too much. You're not too little. If you want to do something and it's really burning within you to do it, just do it. The only thing stopping you is yourself.
Great. And it's not just planting a tree. That's the analogy for anything in life.
Yeah, anything.
Great. Hardest challenge, and how did you overcome it?
Imposter syndrome. The idea of like, why me? Why am I here? Do I deserve to be here? Am I the right person to do this? Like, I'm too young. I'm too this. I'm too that. Right? What I said a minute ago. And in the vein of be kind to yourself, you are also your own best advocate. No one is going to know your worth or necessarily see your worth until you see it first. I mean, there are rare instances, I think, of wonderful mentors and sponsors that have seen in me maybe things I didn't see in myself, but really knowing your own worth and being able to articulate that was helpful to me in overcoming this sense of I don't belong here or I don't deserve to be here. Because the reality is I'm here. I got the seat. What am I going to do with it now? Right? If all you wanted to be was to be in the room where it happened, to quote Hamilton, right? Well, now you're here. What are you going to do about it?
Oh, I love that. Yeah, I don't think a lot of us talk about imposter syndrome, but it is something that ends up kind of blinding you from being able to do your real work. And so being able to overcome it and just say, like, I am here. I deserve this. I'm going to shine and I'm going to make the best of it is key. So thank you for sharing that. Last two, what's most exciting for you about healthcare innovation right now?
Yeah, this is what I mentioned before. It's really exciting to me to see an intentionality around building inclusively from the beginning, designing, building, prototyping, testing with diverse and inclusive populations in mind, as opposed to as an afterthought. So really, I think people are increasingly seeing it as these are intentional customers or a large market, as opposed to a large market to build specifically for, as opposed to trying it in a quote unquote easier population and then going to trying to shift or pivot into Medicaid or pivot, so to speak, into underserved community.
Great. And then lastly, if you could have any superpower, what would it be?
Mind reading. And I say that I have two toddlers. I have a 1.5-year-old and a 4-year-old. And I think it would be fascinating to know what goes on in their heads or in the heads of really anyone else, but the two of them, I think, would be the most fascinating to me.
I thought you were going to say mind reading so you could get people aligned and use the words that they.
I'm sure that there's some professional benefit to mind reading too. No, but I really meant it in the wholly self-serving way within my own household.
Oh, that's so great. I have a 5, 6, and a 7, and I find they are all very different, but it is really interesting to see why they have temper tantrums and or how they, yeah, you're right. Like if I could just figure out what it is that's stopping them from wanting to do something like go to bed, if it's just like water or it's just an extra hug. One thing I have learned though is to use the word, do you want to be helped, hugged, or heard? 3 H's. And if you ask them, I guess that you can do that with a 1-year-old, but when they get to 3, that's been something that has helped categorize. And I do that actually now, even with my own staff. I think about that, not just as toddlers, but with people that I'm trying to, figure out what's the issue with this barrier.
Yeah, I love that.
All right. Well, it's been an absolute pleasure. Listeners, for more on Aditi's work, go to cms.gov or connect directly. It sounds like you're willing to let people check you out on LinkedIn. We'll have both in the show notes, and we hope today's conversation has sparked your curiosity and inspired you to explore further. So thanks for joining us, and until next time, keep on innovating.
Thanks so much.
Thank you for being here.
Did you know that improving preventive care can significantly impact your health plan star ratings? Everly Health Solutions is the leader in at-home testing for health plans. Their convenient, member-centric approach has helped plans achieve industry-leading results. In just 1 year, Everly Health Solutions helped a multi-state Medicare group improve 15 of their plans by at least 1 star. That's a win for members, providers, and the plans themselves. Learn how Everly Health Solutions can elevate your health plan at everlyhealthsolutions.com.